Welcome to our Joint Institute session on the heart of collaborations. Good morning to my colleagues here in Ann Arbor, and good evening to my colleagues in Beijing. My name is Joe Kolars, and I'm a Senior Director, Senior Associate Dean for Education and Global Health here at the University of Michigan Medical School. And it's been such an honor for me to be the co-director for our Joint Institute that started in 2010. When the initial discussions started for a Joint Institute in 2009, the heart of the discussions was cardiology. President Han at that time was particularly excited to see two great institutions try and do things that neither one could do alone. And I would like to compliment the cardiology teams that have really shone so brightly on the potential for collaboration with the Joint Institute. I can't help but reflect on the fact that most of the projects, the majority of the projects and the funding have been in cardiology. I look over the funding, it's been well over 6 million, but the cardiology investigators have tripled that in terms of actual extramural funding. More than 40 papers, more than 25,000 patients involved. So you really have exceeded the high expectations we had for the Joint Institute by showing everyone else how it's done. David Pinsky was commenting earlier that we miss getting together when we're either here in Ann Arbor or there in Beijing. I have to say, the cardiologists are the funnest group to hang with. I always try and crash your parties and your collections of activity because there's so much energy and so much collaboration that's going on. So, so my loud compliments to how you're collaborating, what you're producing, and what I see is a really bright future for our time together. Let me go to the next slide and just make sure we center on what the agenda is going to be. Again, just a few words from me and an introduction from my co-director. We're going to be hearing presentations from colleagues here, and as you know, at Peking University Health Science Center, a bit of a panel discussion and then closing remarks. Next, please. Again, I want it to have hopefully that group feel. What I'm so delighted with, you know, I know cardiologists are big on data, but each year when we gather, this picture gets bigger and bigger because there are more people. Of course, this represents the whole JI. The last time we were able to meet, which was in Beijing in 2019. So I think we'll just keep this spirit of collectivity among us this morning, this evening over today's session. I'm quite pleased that we're also able to regularly transition leadership in the JI, and I'm delighted to be meeting with working with a new co-director who has actually replaced Ning Zhang, who's been a great colleague and will continue to be so. But I would like to make sure everyone knows, especially here in Ann Arbor, that we're really happy to be working with Jidong Wang, who is the new vice president at Peking University Health Science Center for Research. He is, his focus of expertise is in radiation medicine. He so wanted to be with me today for a joint welcome, a joint introduction. Unfortunately, he had one of those family emergencies that often have complicated each of us at different times. But he wanted to just share just a brief video welcome. So I'll turn that over to Amy and Zhao Wei just for his greeting.
Hey, dear Professor colleagues and friends from both Michigan Medicine and the Peking University Health and Center. Good evening and good morning. I'm very happy that all of us can be online here today for the Michigan Medicine Peking University Health and Center Joint Institute for Translational and Clinical Research Bridging Conference on Cardiovascular Medicine. On behalf of Peking University Health and Center, I would like to extend our best regards and appreciation to all the experts and friends present here today. Cardiovascular research has long been a pillar of the GI, with 15 funded projects since the GI was first established in 2010. We have dozens of articles published in famous international journals, which indicates we have made remarkable achievements in the field of cardiovascular medicine. Besides, based on the GI funds, several of the GIPS from PKUHSC have won the National Science Fund for Outstanding Young Scholar, and quite a lot of GIPS have acquired funding from National Natural Science Foundation of China Key Program and the National Key R&D Program. Moreover, our collaboration has also extended to the field of education. Quite a number of PKUHSC junior faculty members have received extensive training at Michigan Medicine, and in the meanwhile, Michigan Medicine students and residents come to PKUHSC regularly for clinical rotation and observationship. I'm really proud of the progress we have achieved so far and hold high aspirations and hopes for our GI, which represents our shared mission and goals, that is, making new breakthroughs in the research of disease to improve health for all. As we enter GI 2.0 year, I hope we can deepen our cooperation with the passion and dedication from the scientists and the faculties involved in the GI. I wish this online conference a complete success. Thank you. Bye.
Great, and a thank you to Professor Wang. And we were discussing vigorously how to actually implement some of our new strategies for what we're calling JI 2.0, big concentration on data science, with some other components that seem to be critical to both institutions. But I'm hoping particularly cardiology can rally around what we're trying to do with data and trying to show the world how two great institutions collaborate. I'm now going to turn the conference over to my colleague, Dr. Eugene Chen. Eugene Chen, I think you all know, he's the Frederick Cutwell Professor of Cardiovascular Medicine and Vice Chair for Basic and Translational Research in Cardiac Surgery. He's the Vice Director of our Executive Committee. And when I think of the successes and the brilliance of cardiology, I'm just so grateful for Eugene's leadership, along with David Pinsky and others. You're really showing the potential of what collaboration can look like. So Eugene, I'll turn it over to you, and I look forward to the session. Thank you.
Thank you, Joe. And good morning and good evening, everyone. It's my honor to introduce today's modulates, and one is from Peking University Health Science Center and Dr. Yida Tang. And Dr. Tang graduated from Xiangya Medical School and did his scientific and PhD training at Peking Union University and Fuwai Hospital, and then went to Yale for research training and stayed at Yale for junior faculty, moved back to Beijing more than 10 years ago. And he joined the Peking University Health Science Center 2 years ago. It's lucky for Peking University has this wonderful scientific leader to join the cardiology at Third Hospital. Currently, he's not only the chair for the department, he also is the chair for cardiac metabolism in the Society of Chinese and Heart Association, Cardiology Association. It's equivalent to ACC. And also he's the current president for Beijing and Precision Medicine. And he's the true leader in the cardiology in Beijing and leading to next and generation of the cardiologists and to the success. And also I'm honored to introduce David Pinsky. David, and it's the individual from the beginning, and we made a trip together and before the institute, joined the institute established. David leading a cardiology team and visit Peking University, meet all of the cardiology leaders, and which including Dr. Han, and Dr. Xian Wang, Dr. Wei Gao, and Dr. Ying Hu. Together, we made historical success together with all of the friends in Beijing. David is the leading and cardiology here, and since 2003, and moved from Columbia to Michigan. We are lucky to have David. He's the one who recruited me to Michigan Medicine in 2005. Thanks, David, and the trust, and in all the years. And David is the world leader and authority to study the relationship and between and blood flow, and also the heart disease and the brain disease. And David, and the floor is yours. Thank you.
Thank you so much for that very kind introduction, Dr. Chen. And Eugene and I go way back, and I'm so pleased to see some of my friends here at this webinar, and this has been a very meaningful institute, and just thrilled to see how it's grown. It's been one where we've done great science and also made great friends, and that can't be underestimated in its power. So welcome. So I'm here to introduce some of our really fantastic speakers, and then my colleague Dr. Tang will introduce speakers as well, and we'll work the program that way. First up is Dr. Scott Hummel. Dr. Hummel is currently the director of our Heart Failure and Preserved Ejection program, our HFpEF program. His administrative leadership, he's the head of our VA cardiology group, and really a national leader in that setting in the area of heart failure. That's a special area of cardiology. But in the area of HFpEF, he really is quite well renowned, and his focus has been on advanced aging and geriatric cardiology. He's a leader in the College of Cardiology Geriatric Council, but also in the role of diet. And I think we're going to learn something here. And HFpEF is a huge problem that we did not recognize many years ago as being a problem, but it's really one of the leading causes of morbidity and mortality in heart failure, and something for which we really need to understand more. And he's got some really terrific practical approaches. And so I'm very much looking forward to hearing what you have to say, Scott.
Thanks so much for the kind introduction and for the honor of speaking today. Go ahead and advance to the next slide and maybe click through as I talk. But David was mentioning how HFpEF has become a more widely recognized problem and has really expanded both in scope and knowledge base from sort of a focus on diastolic dysfunction and a single mechanism to a sort of multimodality failure of cardiovascular and non-cardiovascular reserve. And there's been a lot learned about this over the last decade or so, but not so much on the practical application of these principles to actually taking care of patients in the clinic. And so I have a lot of interest in improved phenotyping of these patients and sort of better targeting of the many therapies that could potentially be beneficial. Go to advance, please. In cardiology training, many times, and appropriately so, we are obviously focusing in on the heart and the heart's physiology and how it affects the other organs in the body. But as I started taking care of more and more patients with heart failure, I realized that it's really, the body is not a generic container for the heart. Many of my patients were older and frail and had challenges with polypharmacy, more medications than was good for them, cognitive impairments and very complex plans of care. And specifically, my focus recently has been on diet and nutrition and understanding how diet affects the cardiovascular system, but also both technological and non-technological ways to improve nutrition in our patients with heart failure. Next slide, please. So I've been looking at several different areas here. The endothelial glycocalyx is really the interface between the blood and the endothelium. And there's been a lot more research into this in the last maybe decade or so as well in fields of sepsis. But in terms of how it might relate to heart failure with preserved ejection fraction, this glycosaminoglycan and glycoprotein layer is heavily negatively charged and attracts sodium, one of the most abundant cations in the bloodstream. And so it's probably why your serum sodium doesn't increase to 160 when you eat a very salty meal. It gets soaked up by the endothelial glycocalyx. In addition, this layer focuses as a mechanotransductor and really is a key aspect of how the endothelium produces nitric oxide in response to shear stress. And it also is quite important in the interaction with immune cells and the endothelium and the process of vascular inflammation. So you can imagine if this layer were damaged, you would have sodium entering the endothelial cells and producing vascular stiffening, sodium going through the endothelium layer and taking water with it, causing interstitial edema and overt edema eventually, immune cells entering in through the endothelium into the underlying layers and causing inflammation and fibrosis and decreased production of nitric oxide. And these are all things that are thought to be key mechanisms in heart failure with preserved ejection fraction. I've been working with our public health school here. We're using a blood test to basically estimate what the endothelial glycocalyx integrity is. And there's a large cohort of postmenopausal women, high-risk cohort for HFpEF here on the Michigan SWAN study. And we've been doing this test in those patients to try to understand what the distribution is in this at-risk group. And on the right-hand side, that graph, the higher the level, the worse the endothelial glycocalyx integrity is. You see that in our patients with HFpEF, the endothelial glycocalyx is quite impaired. So we're very interested in pursuing this further. Going to the sort of practical application and improvement of nutrition and diet, we've been studying medically tailored meals in post-discharge patients. So home delivering meals to patients with heart failure when they leave the hospital. On the left-hand side, in the white bars are the patients who are receiving home delivered meals for 4 weeks. KCCQ clinical summary is a symptom and functional status or functional capacity measure of quality of life. And patients tended to have more improvement of quality of life that were receiving meals. It's a very small pilot study that we're expanding in the near future, but you can see on the right-hand side, there was a tendency towards fewer hospitalizations in the group receiving meals. On the right-hand side is a collaboration with my colleague, Dr. Dorsch from our pharmacy school. This is a mobile application to help people reduce their dietary sodium intake. It uses geofencing technology to know when a patient is entering into a grocery store or a restaurant and basically suggests lower sodium items to them at the grocery store and the restaurants that they might be able to choose. And there we see that there's reduction in sodium intake after several weeks using this app in several different modalities. Next slide, please. Going back to HFpEF patients, how we might better select therapy for them. This is a collaboration with Dr. Daniel Beard in his lab, a physiologist here. On the top layer here, we've been taking clinical data from right heart caths and echocardiography and using modeling techniques to basically show emergent properties from these data like arterial stiffness, ventricular contractility, things you can't easily get from these tests by themselves, and then using unsupervised machine learning to group patients. On the right-hand side is a graph of patients from a clinical trial, and we provided the data to the Beard lab, and they modeled these patients and basically found that all 38 HFpEF patients enrolled in this clinical trial actually had characteristics that were similar to reduced ejection fraction patients. And so, really defining a phenotype and perhaps the inclusion criteria for this study were targeted to capture patients with systolic dysfunction inadvertently. And so you might envision that you could use this technique to better select patients for clinical trials or perhaps improve treatment targeting for patients in the clinic. And on the bottom, I won't go through this in too much detail due to interest of time, but Dr. Beard's lab is doing multi-scale modeling that accounts not just for cardiovascular physiology, but also cardiovascular metabolism. And the idea is that by using these modeling techniques, you can capture what the heart and vasculature are doing during exercise, which is a key aspect of phenotyping HFpEF. Many patients don't have symptoms except with exercise. The phenotypes can be quite different and divergent. Now, next slide, please. So how is all this coming together? So as I mentioned, a collaboration with the School of Public Health, looking at the glycocalyx in postmenopausal women. That's going to be expanded to look at the characteristics of the echocardiograms as compared to glycocalyx integrity and incident cardiovascular disease in this population. My colleague, Dr. Sasha Gunawardena, is studying how the monocyte glycocalyx may interact with the endothelium and with heart failure physiology. I lead a dietary trial at the VA in which we are using a mobile application and dietary counseling to help people adhere to the DASH diet mobile application. And we're using the glycocalyx as a marker for salt sensitive improvements in cardiovascular function. The DORSH team, I mentioned that we're using this geofencing sodium reduction. There's an NIH grant to reduce blood pressure and also a heart failure related study. I'm going to be leading a large VA multi-center trial expanding the home delivered medically tailored meals program. It's targeted to reduce readmissions, but I think there will be lots of opportunity for ancillary studies looking at mechanism. I'm again working with the Beard lab to use this physiologically informed machine learning to phenotype HFpEF patients for treatment selection. And I still will remain interested in geriatric phenotyping and how these properties of the patient affect their long-term outcomes. Thank you very much.
That was terrific. Please submit your questions, and that way, when we have our panel discussion, we can all have that as conversation and learning. Next up, I'd like to introduce Dr. Salim Hayek. Dr. Hayek has really become quite a leader, both at Michigan Medicine and nationally. His particular interest is in cardio-oncology. He is a cardiologist. He also does preventive cardiology. And his specific scientific focus, for which he's become very well known, is on the use of biomarkers and the understanding of biomarkers as predictors of risk. Dr. Hayek is published in the very top tier journals of our day. He's published in the New England Journal of Medicine multiple times, Nature Medicine, British Medical Journal, and many others, so very well published. His particular scientific theme is understanding the role of the urokinase plasminogen activator receptor, UPAR, as a predictor of risk for both heart and kidney disease. He's won quite a number of awards, the Samuel Levine Young Investigator Award. He's won the Douglas Zipes Young Investigator Award. These are the top awards across at least America. And so he's really quite renowned, and we're very lucky to have him joining our conference today to teach us. Dr. Hayek.
Thank you, Dr. Pinsky. Thank you for having me. I mean, this is a perfect opportunity to showcase what we are doing at the cardiac lab here at the University of Michigan, and hopefully trigger some collaboration. Here I entitled this just 5 minutes of showcasing our research as biomarker to biomaker, really to exemplify the translational research that happens in our lab. Next slide. So our lab encompasses really translational research that is focused on advancing patient care. And our research activities are really broad. And that is why it's difficult to define within a specific scope, but we really work on bench to bedside, from experimental models of cardiovascular disease, using findings that are derived from our clinical work, to also being a biomarker core lab in which we've measured the various biomarkers from highly valuable samples from clinical trials, large cohorts, and cohort we have built ourselves here at the University of Michigan, such as the bone marrow transplant registry. This is the largest bone marrow transplant cardiovascular registry worldwide, which includes about 4,000 patients. We've also built in this pandemic the Michigan Medicine COVID-19 cohort, which is a biorepository and a very carefully defined clinical cohort of now including 3,500 patients with COVID-19 in whom we have biosamples collected. And as I will show shortly, we've made several advances in understanding COVID. And a lot of this work has led to the development of clinical trials, which we also perform. We've really been focused on phase 1 trials, targeting soluble urokinase plasminogen activator, which I will showcase here the next slide. Next slide, please. So this model, that expansive model of research, has really been has led to significant major productivity over the past few years. We've published 70 papers since 2018 alone, very impactful with 6,000 citations. We've had numerous intramural and extramural award, number of patents undergoing licensing, and our work has been acknowledged. Next slide. One of the particular areas of interest of mine personally, and that has been derived from my work in cardiovascular research, is highlighting the immune system as the link between cardiovascular and kidney disease. Forever, we've known that both organs are tightly linked, but therapies that are currently available in use or that have been tested and to treat cardiovascular disease in patients with kidney disease and vice versa have really been ineffective. And we have identified the immune system, the innate immune system specifically, as a major player leading to both, and is likely the major link between kidney and cardiovascular disease that we are seeking to target. Next slide. And one of the major actors that is derived from the innate immune system is soluble urokinase plasminogen activator receptor, or SUPAR. SUPAR is a signaling glycoprotein that is produced by immune cells, mainly neutrophils, macrophages, and some other immature myeloid cells that are produced at very low levels. It is not an acute phase reactant. It is not. It does not rise acutely with various insults, but rather very specific triggers increase, such as smoking and diabetes. Next slide. And in the past few years, we've really published numerous high-impact papers placing SUPAR as a pathogenic factor rather than a biomarker of both kidney injury and now more recently cardiovascular disease. It all started with identifying it as a biomarker of risk, and now we are actually targeting it. Next step. Next slide. So based on all the research we've done in the past 5 years, we actually are starting the first phase 1 clinical trial targeting SUPAR, and this is specifically in patients with COVID-19. What we found was that COVID-19 is one of the major triggers of SUPAR, and which may explain why the incidence of acute kidney injury is very, very high in that patient population. And in an NIH and industry co-sponsored trial, we are using a dialysis machine with an adsorber that extracts SUPAR selectively, and we are testing it in patients hospitalized with COVID-19. As a primary outcome, we're looking at safety, but also we're looking at figuring out, how much SUPAR we can remove. How does it rebound? How does removing it affect other markers? And most importantly, we're looking at any signal of its impact on kidney function in this high-risk patient population. Next slide. And this is derived from our work on the Michigan Medicine COVID-19 cohort. This is a very special cohort because what we've done here is that we've reviewed every single patient coming into the hospital with a positive SARS-CoV-2 test. We reviewed manually with chart review and collected extensive data. What we've done here is that we've differentiated people who were hospitalized specifically for COVID versus those who came in with a positive COVID test. And so this is a unique cohort in that it's manually curated. There's blood samples collected from the admission, not from random times during the hospitalization. And it is systematic in the sense that we've collected data on every single patient who came in for COVID-19. And now it has enrolled about 3,500 patients, and we have over 8,000 samples collected from during the hospitalization. It has allowed us to get a lot of funding related to advance our work in understanding suPAR, and we've established major collaboration across the world with other centers. Next slide. And that again has led us to a number of high impact publications. The latest one and the most impactful one in my mind is the relationship between diabetes and COVID-19. Diabetes is a major risk factor. Oh, can you go back, please? Diabetes is a major risk factor for COVID-19, and for reasons that were poorly understood. And we recently published in Diabetes Care showing that actually suPAR levels encompasses the entire risk attributed to diabetes in COVID-19. Patients with diabetes are known to have high suPAR levels to begin with, and they become even higher in COVID-19. And what we found was that actually hyperglycemia is an independent risk factor, independent of inflammation. But this is one of the major triggers that have indicated a specific role for suPAR in diabetes. Next slide. Now, in a very different part of our portfolio, I'm a clinical cardio-oncologist. I see patients with cancer, and I'm really interested in establishing evidence-based strategies to advance the cardiovascular care of patients, of cancer patients. Next slide. And one thing we have done here is established CARE BMT, which is the University of Michigan Cardiovascular Registry in bone marrow transplantation. It is the largest cohort of patients undergoing bone marrow transplant, and includes now over 3,500. And it's continuously enrolling these patients. And essentially what this cohort compared to other registry does is that it really focuses on the detailed cardiovascular characterization of these patients to fill a major evidence gap, in the sense that we do not know how to identify patients who are high risk of cardiovascular outcomes in bone marrow transplantation, and to better determine who's eligible and who's not eligible for transplant. So these findings are going to inform the first guidelines for pre-transplant cardiovascular evaluation, which we are currently writing. Next slide. And other cardio-oncology projects include, again, the use of blood-based biomarkers to better characterize these patients. One of our major areas of interest is immune checkpoint inhibitor myocarditis. This is a dreaded complication of immune checkpoint inhibitors. These are wonder drugs that are being used more commonly in cancer. We're also looking at a more interventional impact, the impact of certain interventional net patient populations, such as the use of the Watchman procedures. And overall, we're establishing a clinical cardio-oncology registry that is multi-centered and will collect detailed data on how we assess these patients. And then I believe that's it. Next slide. So this is, just to summarize, this is really the focus of our lab, which is ever evolving. We're focusing on the study of inflammation here, suPAR, and kidney cardiovascular disease. We have a portfolio in cardio-oncology, and again, we have a major and continuously enrolling COVID-19 cohort, and are actually studying long COVID by inviting in work funded by NIDDK. We are inviting these patients back for extensive characterization for long COVID. And that's it. Thank you.
That was terrific, Dr. Hayek. One thing I hope everybody is seeing from this is between HFpEF, which is, I know, a major problem both in China and America, and with the need for biomarker assessment and new therapeutics, hopefully this type of bridging seminar allows us all to develop collaborations. That's really one of the goals of today. So I can already see many possibilities, and I'm looking forward to hearing Dr. Tang, your cohort of scientists, and what they have to say. So for our next scientist, we're going to introduce Dr. Daniel Lawrence. Dr. Lawrence is the Frederick Heatwell Professor here. He is a wonderful scientist. He has been one of the world leaders, probably the world leader in neuroserpin biology. His interest is in vascular disease and the brain in particular. And he's done a lot of amazing things with his career, but I think most especially, he's looked at tissue plasminogen activator substrate, which is platelet-derived growth factor C, and the use of an agent for cancer treatment, imatinib, and its possible role in stroke. And he's taken that from the very fundamental discovery science published in, I believe, in Nature Medicine, and taking that all the way through so that it's now in a clinical trial phase. So we're going to learn how this might be a therapeutic. So Dr. Lawrence is really a card-carrying serine protease scientist and a wonderful colleague and collaborator in our section of cardiovascular medicine. Dr. Lawrence.
Thank you, David, for that introduction. So I am very much a basic and translational scientist. We don't do a lot of work in the clinic. We try to pass these off to the folks, as David said, to get them into discoveries into the clinic, but that's not work that we do ourselves. Could I have the first slide? So the lab focuses on really three main areas of disease, and most of these are using mouse models. So a major focus in the lab is the vascular biology of the central nervous system. So we focus on the blood-brain barrier and vascular remodeling and angiogenesis during recovery from injury. In particular, we use ischemic stroke models, and we have models of Alzheimer's disease, and are interested in the role of the vasculature in promoting these, and in particular in Alzheimer's. That's a new area that we're very interested in. We also study neurodegeneration. Started out, of course, in relation to the vascular impact of disease, but now we're looking directly at neurodegeneration and how that is associated with the innate and the adaptive immune response. We're very interested in the regulation of diapedesis of peripheral inflammatory cells and how they enter into the brain in many of these neurodegenerative diseases. We study this in models of Parkinson's disease and models of Alzheimer's disease, and the interface between the vasculature and the neurovascular unit, and how that interface affects the progression, initiation, and progression of disease. And then lastly, we study fibrotic disease. We're very interested in the role of fibrotic disease in the periphery and as well as in the brain. We do a lot of work in pulmonary fibrosis. We're studying systemic fibrosis as well. This is a more translational study. We have done a lot of small molecule, high throughput screening, identified targets, gone after those targets, and are trying to develop novel therapies for the treatment of fibrotic disease. But I have the next slide. So in the areas that we're working on, the hot topics that we see, particularly in the vascular biology of the CNS, is one of the very emergent questions is how important is vascular dysfunction in the development of Alzheimer's disease? So this is a very interesting question that's really only sort of come to the surface in the last few years. But it's quite interesting. If, for example, if you take patients with familial mutations that result in Alzheimer's disease, so you can actually predict with some accuracy when they're going to start to develop the cognitive manifestations, and you follow these patients early on, what they found is that the earliest manifestations that they can see actually turn out to be vascular impairments in either vascular reactivity or cerebral blood flow, and these precede any of the cognitive deficits. So we're currently very interested in how the systems that we're working with are affecting the vascular remodeling that's associated with Alzheimer's. Neurodegeneration. So there's quite an interest. This is a little bit more mature than the vascular remodeling in AD, but how does the blood-brain barrier dysfunction play a role in the development of neurodegenerative? Is this a cause or a consequence? Obviously, as you start to get neurodegeneration, there's going to be inflammation, and inflammation is going to affect the blood-brain barrier. But is it possible that insults that lead to dysregulation of the blood-brain barrier or the neurovascular unit lead to neurodegenerative diseases in ways that we don't fully understand? And then fibrotic disease is a major pushes now in trying to understand the progression of fibrotic disease. Fibrotic disease, as you're probably aware, can account or be associated with as much as 40% of deaths in the developed world. It's abnormal wound healing, and it can be found in any organ. And we're very interested in the mechanisms that promote fibrotic disease across organ systems. One area that people are very interested in is the regulation of cellular senescence. Is senescence a good thing or a bad thing in the case of fibrotic disease? And there's a lot of work right now in trying to develop therapeutics. And we've actually we have identified a target in that area. And we have a startup company that's trying to push that into the clinic. We recently received some Series A funding for that. So we're hoping to test some of our ideas on treating fibrosis in systemic sclerosis within the next year and a half or so. Can I have the last slide? So the ongoing projects in the lab, these are things that we're very interested in and that are, for the most part, funded at this point. So we're looking very closely again at what's driving this vascular remodeling in Alzheimer's disease, again, cause or consequence. We have some very interesting results in neurodegeneration in Parkinson's and Lewy body disease that we think links the generation of these two neurons to the adaptive immune response and the infiltration specifically of cytotoxic T cells in case of Parkinson's disease. We're very much interested in trying to improve therapies for ischemic stroke. That's a big area in the lab. That's, as David mentioned, we've studied repurposing of approved pharmaceuticals for the treatment of ischemic stroke. We have followed up on that and are identifying downstream targets that we've been in that pathway that also seem to have benefit in the treatment of ischemic stroke, and we're hoping to push those forward as well. And then lastly, as I mentioned, we're very much characterizing the mechanisms that are driving fibrosis. How does cellular senescence, for example, promote or relate to the fibrotic response? And I'll stop there. Thank you very much.
So Dr. Lawrence, that's just terrific. I will just tell my colleagues, I know that stroke is a major issue in China. It's obviously a major issue in America. And so there's some very exciting work here. And Dr. Lawrence and I have our laboratories just next to each other on the same floor of one of our research buildings. And he's a wonderful colleague and collaborator. So for those of you who think these areas are interesting, which might be all of you, but please seek him out. He's just a terrific collaborator. I'd like to next introduce the last Michigan panelist. That's Dr. Ahmed Abdel Latif. Dr. Latif just recently joined us at Michigan Medicine. We were very fortunate to recruit him. And he's really an amazing scientist. He's a cardiologist, an interventional cardiologist, but much of what he does is in the scientific domain. And he studies molecular and cellular mechanisms of pathological cardiac remodeling. He will tell you about that. He's very focused on cardiac stem cells, injury repair after ischemia. And he uses all of the sophisticated molecular tools that one could imagine. Not only that, he's got a really very interesting model. I'm not sure if he'll be presenting that on aging. And aging is something that we are focusing on at our cardiovascular center as a thematic focus, how and why the cardiovascular system ages. So if he tells you about that, he's got a very unique and interesting model, and he's been a wonderful mentor, colleague, and we're very lucky to have him new to our Joint Institute efforts. Dr. Abdul Latif.
Thank you, Dr. Pinsky, for the kind introduction. As Dr. Pinsky mentioned, I really appreciate this invitation to participate in this excellent collaborative effort. And I thought I would use this time to highlight some of the active projects in my laboratory, and all of which are potential collaboration opportunities. As Dr. Pinsky mentioned, I'm a physician scientist, and my research encompasses both basic translational as well as clinical studies, which are focused on the molecular and cellular mechanisms of pathological cardiac remodeling. And specifically, my lab explores, sorry, I'm not sure if you guys can see me, but my lab explores the molecular mechanisms of innate immune response after myocardial injury and its role in heart failure and as well as cardiac recovery, using both in vitro and in vivo studies. To this goal, we integrate human, biochemical, cellular, animal, and pharmacological methods in our projects. And our goal is to enhance myocardial preservation in the setting of injury. We utilize a unique bedside to bench and back to bedside approach in our projects. Next slide, please. So a major component of my research.
I'm sorry to interrupt, Amit. If you might be able to turn on your camera. I mean, we hear your voice and see your slides, but if that's possible.
Yeah. Okay.
Wonderful. Wonderful. Yeah, that way people can see you as you talk. Wonderful. Thank you.
Perfect. So a major component of my research focuses on translational and first-in-human studies. This is an example here of an FDA IND protocol that we completed in my previous institution, examining the role of autologous bone marrow-derived CD133 endothelial progenitor cells in patients with end-stage heart failure and no revascularization options. This study is being published in the next month or two. Next slide, please. And one of the major areas of focus in my laboratory as well is understanding the pathways regulating the innate immune response after myocardial injury and its effect on cardiac recovery. These studies are supported by a biobank of human subjects admitted with acute myocardial infarction and utilizes various animal models with genetic alterations modulating various aspects of the immune system and its signaling. In these studies, we focus on lipid signaling pathways, especially the role of lysophosphatidic acid or LPA in regulating macrophage polarization and immune response after tissue injury. Next slide, please. Together with these collaboration potentials, we recently described a very unique animal model, a novel model of innate cardiac regeneration in an adult mammal. This animal model has been recently published and collaborated by other groups, and this model actually overcomes some of the limitations of the current approaches, which have not been successful in terms of clinical translation because of the knowledge gap between regenerative biology and clinical medicine. So indeed, the lack of the mammalian heart regeneration models represents a significant challenge in identifying a roadmap for mammalian regeneration. In this model that we recently published, African spiny mice or Acomis cahernis represent a novel model for adult heart regeneration with remarkable resistance to heart failure after a heart attack. This mouse model could represent actually a blueprint for future studies focusing on adult heart regeneration after ischemic injury. We have recently completed some preliminary studies looking at single cell and single nuclear RNA sequencing from this animal model, which shows significant contribution of macrophages and their polarization status and their effect on angiogenesis in the recovery of the heart after ischemic injury in this model. And we basically are designing new studies now to test these in vitro and in vivo models, and in the future in human studies. I would also want to add, as Dr. Pinsky mentioned, that this model is very unique also in terms of heart aging and how the cardiomyocytes maintain a young phenotype throughout the lifespan of this mouse model, which is up to 3 years. Basically, we are conducting studies now trying to understand the pathways that maintain the young cardiomyocyte phenotype in this model. And as I mentioned, all these are potential collaboration opportunities, and I look forward to an active discussion in this panel and future collaborations.
That's terrific. And Ahmed, I don't think you can work fast enough, because I think with your spiny mouse, you might have the fountain of youth for cardiovascular aging. So please work quickly on that. Yeah, and again, new to the collaboration, and I hope our colleagues take advantage of collaborating with any of these fine investigators. Now I'm going to turn the program over to my esteemed colleague, Dr. Tang, and I very much look forward to hearing from your scientists as well.
Thank you, Dr. Pinsky. I think we would find some points in the collaboration with too many aspects, like from HPF to the stem cell. Thank you so much, and thank you, Dr. Chen, for introducing our team. We have 4 team members in our team. My name is Yida Tang from the Peking University Third Hospital, and we have other 3 panelists, Dr. Jianping Li from the Peking University First Hospital, and Dr. Xunde Xian from Peking University Institute of Cardiovascular Sciences, and Dr. Yuxuan Guo from Peking University Health Science Center, the key laboratory of molecular cardiovascular science. And I will introduce each speaker when they start their speech. Can I have my slides, please? Or should I share my screen?
I think it looks like they're sharing it for you, I think.
Oh, I see. Okay, yeah. In the Peking University Third Hospital, actually, we have the clinical department of cardiology, and also we have the Institute of Vascular Medicine. Next, please. Our clinical part actually was built in 1987. Well, just like the Eugene said, I'm new in this team. I'm here only for 2 years, but this team actually has a long history for the clinics and as the institute. In the next year, when the clinical part was built, the vascular institute was built in 1988. And in the China, or especially in the interventional cardiology, so the Peking University Third Hospital has the very fundamental or the frontiers in this country. For example, in 1990, so the Third Hospital is the first group of the emergency PCI was done, especially for the green channel, for the acute coronary syndrome, and also in 2014, almost the first group of cardiac rehab center in China was built in the Peking University South Hospital. When I came here in 2020, we set up the cardiometabolic clinics. That's the first cardiometabolic clinics in China, and we also have the cardiometabolic the ward was built last year. And then we have also the structural heart disease center, and the digital health and the telemedicine center was built up this year. So we have the telemedicine before, but right now we build a big center in the whole the hospital, and also we have the 49 community hospital linked together as a network. Next slide, please. So that's the layout of the clinical part. For the angio, corneal angio, we have almost 5,000. And for the PCI, the annual PCI number will be like around 3,000. For the EP and the pacemaker implantation, around 1,000. And for the TAVR, around 100. And also we have the ASD, VSD, the adult congenital heart disease with around 100 as well. Also, for the subspecialties in the clinical part, we have the 10 subspecialty, including the echocardiography, including the structural heart disease, including the cardiometabolic, including the EP and the pulmonary and the cardiac rehab. We have a long history of the cardiac rehab. And also right now there's a very new center for the digital health, and the telemedicine center was built up just a few months ago. Next slide, please. For the research part, of course, we're looking into the big data, supporting our CDSS. It is a clinical realization support system. And also we have the AI telemedicine with wearable devices, collaborating with other enterprises. And also we have the community health, which is the health community with also the AI system. We call it as active health approach for aging. So that's why when Dr. I think Dr. Latif has the aging model, or probably we can talk in the future. Next slide, please. Also, there's 3 other parts for the hospital and enterprises joint program. One is a magnetocardiography with the 北航怎么说来着？ and also we have the hydrogen treatment for the heart failure, especially for the HFpEF. And also we also have the structural heart disease, the new devices making. So next slide, please. For the basic research, our focus is even we have the Institute of Vascular Medicine, we focus on metabolic cardiovascular disease or the cardiometabolic disease. So we including the cardiology, the internal medicine, some colleagues and some colleagues from the endocrinologist. So we're looking into the population-based or the bench-based research in this field. Next slide, please. So one is from the observational study. We found some the prevalence or the link between the different factors and the disease. And also we look into the mechanism from the animal models, and then the launching the clinical trials. So for example, one of my researchers, one of my focuses is around like the thyroid dysfunction and the heart disease, including the myocardial infarction and the heart failure and the lipids profile. So we launched the series clinical trials. We call the thyroid heart for the AMI, which means the acute coronary syndrome with the hypothyroidism, heart failure with a hypothyroidism, or the dyslipidemia with a hypothyroidism for the medicine treatment. Next slide, please. And another focus will be the nephew in the heart disease. Next slide, please. That's only the outline for the research. And HFpEF is another topic, is a hot topic. One signal pathway, we focus on the HDAC. Actually, we have in collaboration with Dr. Jiu in the Southwestern. And the next slide, please. Also focusing on the HEPAF. So another pathway RNA. I think a lot of researchers look into this part as well. Next slide, please. Also, we look into the mitochondrial in the HEPAF, look into the treatment strategy. Thank you very much. And if I may, I would like to introduce our next speaker, Dr. Jianping Li from the Peking University First Hospital. And Dr. Jianping Li, not only a very famous interventional cardiologist, but also a very famous as a hypertension expert. He found the very big part for Dr. Li is H-type hypertension. And the folic supplementation in the stroke prevention in China, just like Dr. Pinsky said, stroke, especially the hemorrhage, is very high prevalence in China. Dr. Li found that the high homocysteine level significantly amplify the risk of stroke in Chinese hypertensive patients, whereas folic acid supplementation significantly reduce the risk of stroke on the basis of the blood pressure control. This work actually published in the JAMA, and Dr. Li also received the National Science and Technology Advancement Award in the dyslipidemia. Thank you, Dr. Li.
Thanks, Yida, for your kind introduction. Hello, everyone. I'm Jianping Li from First Hospital, Peking University, and I'm now the director of Department of Cardiology. So next slide, please. Next slide. So currently, my major research interests are focusing on the 4 fields, including precise prevention of stroke by concomitant control of blood pressure and hyperhomocystinemia, pressure wire-free coronary hemodynamic evaluation, mechanism study of air pollution on cardiovascular disease, the screening and management of familial hypercholesterolemia. Next slide, please. The work of precise prevention of stroke started like more than 20 years ago. Firstly, we discovered that hypertension and hyperhomocystinemia have a joint effect on risk of stroke by a long-term follow-up cohort. And we found that subjects with both hypertension and hyperhomocystinemia have more than 10 times higher risk of stroke compared to those without hypertension and hyperhomocystinemia. And the subsequent epidemiologic data showed that around 75% of Chinese hypertensives have hyperhomocystinemia. And to emphasize this important issue, so we proposed a name, H-type hypertension, refer to those with both hypertension and hyperhomocystinemia. Our meta-analysis showed for the first time that folic acid supplementation could reduce the risk of stroke in population, especially in population without folic acid fortification. And a subsequent RCT, which is called China Stroke Primary Prevention Trial, confirmed that concomitant control of blood pressure and the homocysteine level by enalapril 10 milligram per day and folic acid 0.8 milligram per day could further reduce the risk of stroke by 21% compared to those receive only antihypertensive therapy. And in the future, we will perform further RCTs to evaluate the different dose of folic acid supplementation in different MTHFR genotype subjects. Next slide. And we have long been interested in evaluation the hemodynamic significance of a coronary lesion. So we have collaborated with a medical device company and have developed a system based on pressure fluid dynamic to evaluate a fractional flow reserve without a pressure wear. And the confirmation study showed that the system is very accurate in evaluating the lesion significance. And this will guide us, when we treat the coronary artery disease, whether a lesion is significant or not. And in the future, we will use this system to evaluate the IMR in those patients with evidence of ischemia, but their coronary artery is normal. Next slide, please. So the mechanism study of air pollution on cardiovascular disease initiated several years ago based on our previous JI project. In that project, we collaborated with Dr. Brooke Robert in University of Michigan and Professor Wei Huang from Peking University Public Health. And we found that short-term exposure to PM2.5 could significantly influence the function of HDL and the plaque stability. And these results were published on Circulation Research and ATVB. And after this project, several subsequent projects have been successfully applied both in China and in the US. Next slide, please. So next, I will introduce one of our ongoing JI project, overcoming interpatient variability in antiplatelet therapy. And our collaborator in UMMS is Professor Daniel Eisman and Professor Haoming Zhang. Next slide, please. So we all know that with a combination of aspirin and P2Y12 inhibitors is the standard therapy in ASS patients receiving PCI, while clopidogrel is the most broadly used P2Y12 inhibitor. However, approximately 2/3 of the Asians are poor responders to clopidogrel due to lack of active metabolites in CYP 2C19, loss of function allele carriers, and diabetes. So our UMMS collaborators have found a novel conjugate of clopidogrel, referred to as ClopNPT, could dramatically increase the efficacy of antiplatelet compared with clopidogrel. Next slide. So next slide. I just show the result. So based on the data for the first enrolled 180 Chinese ASS patients, we found that the CVP 2C19 loss of function genotype contributes to the inter-individual variability to clopidogrel therapy by influencing the concentrations of clop, the active metabolites, and the novel conjugate of clopidogrel could efficiently overcome this inter-individual variability. And so far, we have finished enroll the total study subject, which is 300, and we will test our initial finding in our total population. Next slide. So that's all. Thank you.
Wonderful talk. And I would like to introduce our next speaker from the Peking University side. And the second speaker in our panelist will be Dr. Xian. Dr. Xian is currently an assistant professor and a PI at the Peking University Institute of Cardiovascular Sciences. Before joining the Peking University, Dr. Xian was assistant professor in the Department of Molecular Genetics at the UT Southwestern Medical Center. His long-term research interests focusing on the effects of lipoproteins and the lipoprotein receptors on the variety of metabolic diseases, including atherosclerosis, diabetes, and obesity, and neurodegenerative diseases. Dr. Xian's lab has successfully established many genetically modified hamster models of dyslipidemia, systemically elucidating advances of hamster models in the field of lipid metabolism and cardiovascular disease. He was also awarded as the 2020 Outstanding Young Talent Award by China Experimental Animal Association. Thank you, Dr. Xian. Welcome.
Oh, hi. Yeah, thank you, Dr. Tang's introduction. Yeah, so I'm Xinde Xian from Peking University. Nice slides, please. So the long-term goal of my lab just focus on the relationship between the dyslipidemia and the metabolic disease, such as the atherosclerosis, and the fatty liver, obesity, and the diabetes, and Alzheimer's disease. So as we know, so the lipid metabolism is very important to the whole body, and the impairment of the lipid metabolism is the pathogenesis of the metabolic disease. So in our lab, so we just use the CRISPR-Cas9 to delete the gene of interest from mouse and hamster, and then we investigate the 3 types of dyslipidemia, such as the hypercholesterolemia, very low HDL, and the hypertriglyceridemia. And then we use our model to evaluate the efficacy and the safety of the AAV-mediated gene therapy. So next slide. So next slide, please. And yeah, so the hot topic in our field, or we can say the big issue, so is the how the basic research can be translated so into the clinical study, because when we use the mouse model, we find the big metabolic difference between mouse and the human. So that's why, so in the couple years, so the cell metabolism, the secretion, and the AHA, so they just publish a lot. So the research article and the comments or the scientific statement, and to discuss this issue. So they agree. So so the mouse model, the data from the mouse model can partially explain the human disease, such as the lipidemia and the atherosclerosis, but they also suggest the more species need to be considered for the better understanding the human disease. And the next slide, please. So in the field of the lipid metabolism, so we know, so under Dr. Mike Brown and Joe Goldstein from UT Southwestern, they used the human fibroblasts and the CHO to discover the LDL receptor and the regulatory mechanism of the LDL cholesterol transport. And this is very, very and the classical, pathway to explain so what happened to the FH patient, and then leading to the application of statins to treat the patient and with the elevated LDL cholesterol. So before I returned back to China. So they these two GN, they just told me so, and they also use the wild type hamster to study the the lipid metabolism in the liver, and the data was convincing. So they also thought that the hamster is a great model for the lipid study. So when I come back to China, I just work with the Professor George Liu, who just retired so last year, and we established the transgenic core of the hamster model in Peking in the Peking University, and that's why today I'm here and just looking for the collaboration. So with UN, because we know the UN has the wonderful the human database and the basic research, and it's easy for UN to identify the new gene and the new mutation of the gene who will be the potential contributor to the dyslipidemia in the cardiovascular disease. So if possible, we can build out the Sino-US collaboration to generate the knockout or the transgenic hamster model for the translational research of the cardiovascular disease. And thank you.
Thank you, Dr. Xian. Yes, as we know, that's the animal model, especially the specific model is very helpful, although the key point for the mechanism launching pneumatic diseases such as the dyslipidemia. Thank you. And now I will welcome our last speaker in our panelist, Dr. Yuxuan Guo. Dr. Guo received his PhD from the Johns Hopkins University in 2015 and received his postdoc training in Dr. William Pool's lab at the Boston Children's Hospital from 2015 to 2020. Dr. Guo joined the Peking University Health Science Center at the end of 2020 as the principal investigator. Dr. Guo applied recombinant adeno-associated virus and the CRISPR-Cas9 system as the major tools to study heart development and pathogenesis and the regeneration. His current research focusing on the development of novel technologies for cardiac gene editing and gene therapy. Dr. Guo was also awarded as the AHA Postdoc Fellowship and the NHA K99 Award. Welcome, Dr. Guo, your slides.
Thank you, Dr. Tang. Can you hear me?
Yeah, clear and loud.
All right. All right. Thank you, everyone. My name is Yuxuan. It's a great pleasure to have this opportunity to introduce myself, as well as the work that we have been doing in the last couple of years. Next slide. Next slide, please. All right. So for a brief introduction of myself, about 10 years ago, I went to the Johns Hopkins to study developmental biology with Yixian Zheng at excuse me, can please go back the slide. Excuse me, can my slides go back?
I think there's a time delay, and
all right.
You need the John Hopkins slides. Go next.
Oh, all right. I think there's probably a delay of my internet. So basically, the very first question that I was interested in was how an animal was formed in the uterus. So when I observed that using a mouse as a model, we saw that the first organ that we can see probably is the heart. So why are we interested in the heart development? So people told me that the defects in heart development were resulting in congenital heart disease, which is the most common birth defect in human.
It should be.
So that's interesting. That's interesting, but that's also the paradigm. So when we talk about adult heart disease, do care about heart development. To solve that problem, I went on to join William Pool's lab at Harvard Medical School and the Boston Children's Hospital to study a very unique developmental process that we call the heart maturation. Please go to the next slide. So heart maturation, basically we define this as the process of heart development starting from the very beginning after cardiomyocytes form to the very end of postnatal heart development. Basically, it's the whole process from the formation of cardiomyocytes all the way to the end of development when we become adults. This is pretty much a gap of knowledge in heart developmental biology. So cardiomyocyte maturation is important for three pieces of reasons. First, currently stem cell derived cardiomyocytes appear immature in vitro and in many cases in vivo. So although there are many different people trying to use iPS cell derived cardiomyocytes to model heart disease, because they are immature, the disease modeling is usually not very accurate. Secondly, in most mammals, heart regeneration capacity decreases during heart maturation process. They are inversely correlated. So we believe by studying heart maturation, we can have a unique idea of how we lost the regeneration capacity to begin with. And in that way, we can probably develop new methods to boost heart regeneration. Thirdly, as I asked at the very beginning, when we talk about heart development, we talk about congenital heart disease. But is that all what heart development is about? Since a lot of happen postnatally in heart development, we believe heart maturation probably is a new angle to look at how adult heart disease are developed. Next slide, please. So in order to answer the questions I have been asking about, we recently have developed this new technology that we call Cas-AAV. Basically, the core component of this system is based on adeno-associated viral vectors, especially the serotype 9, AAV9, which so far has been a very successful vector for gene therapy with a drug available in the market. The second component of this system uses a CRISPR-Cas9 system as a tool to do genome editing in the cells. And we developed this system that allows us to quickly and efficiently delete pretty much any piece of DNA in the mouse system using a CTNT cardiomyocyte specific promoter as a driver, so we can do quick and efficient gene knockout in a cardiomyocyte specific manner in this system. Next slide, please. So build on this new tool, we are trying to reform the way we study the heart using the mouse as the model organism. Pretty much the first advantage of this system is that it's very flexible. We can pretty much study any gene we want within 3 months since we decided to do it. So in the last 5 years, we have published 5 papers knocking out five different genes and study each of the genes to see if they have a new role in heart development and cardiomyocyte maturation. The second advantage of the Cas-AAV system is that we are able to control how many cardiomyocytes are actually mutated very easily by just controlling the virus dosage. In this way, we are able to create like so-called a genetic mosaic in which among all the cardiomyocytes, only a very small number of cells are deleted, genetically manipulated. So we can study the direct cell autonomous function of the gene of interest without worrying about that the overall heart function get messed up. So we are seeing the heart failure phenotype, but not seeing the direct immediate downstream effect of the gene function. So the third and very exciting new advance of the Cas AAV system, co-developed by my colleague Nathan Van Dusen, published last year, is that we have established this high throughput CRISPR-Cas9 screen system in the animal heart. Basically, we can design and create an AAV pool carrying thousands of different guide RNAs and deliver them in the heart to knock out a pool of genes we want, and use a cell-based reporter assay to combine it with next generation sequencing to see what genes act in what function that activate the reporter. So in the very recent study, we have successfully studied over 1,000 genes in a single heart and identified over tens of new genes that play a new role in the heart development and cardiomyocyte maturation. Also, next slide, please. So also we are also building new gene therapy and gene editing tools for cardiomyocytes specifically. For example, we can now knock out any gene in the heart, in the cardiomyocyte, using an all-in-one AAV vector that we haven't yet published that allow us to expand the usage of this Cas AAV system. We also developed base editor based at nucleotide substitution system, still using our AAV as a tool, so allow us to precisely make point mutations, specifically in cardiomyocytes in vivo. These new tools, we believe, will be very helpful for you to study whatever gene you want. If you study in the cardiomyocyte using a mouse, using a mouse or even spiny mouse model. Thank you very much, and I look forward to the opportunity for collaboration.
Yeah, wonderful work. Thank you, Dr. Guo. And I think we closed all the speeches, and Dr. Pinsky, probably right now is the Q&A session.
Yeah, that was really, thank you. I loved hearing of your work. We're running a little bit late, so it'll be a short panel discussion, but I see there's already some questions coming into the Q&A. This one is for Dr. Lawrence. How do you measure brain blood flow in your studies of Alzheimer's disease?
Yeah, that is a difficult problem in mice. The way we are doing it is we can measure flow across the surface, first millimeter or so, using laser speckle imaging. For deeper measurements, currently we're doing modeling. So we use brain clearing techniques and vessel painting, and we can image the entire vascular bed of very large sections, and then we're using modeling for the flow. We're investigating some new techniques to actually hopefully get real flow measurements in the deeper parts like the hippocampus. Right now, we can only really accurately measure the top millimeter or so of the brain surface.
That's great. There's a question that didn't come in through the chat. Actually, that's a comment. Dr. Hummel, one of our panelists, had to leave for a clinical duty, but he's very interested in learning more about the HDAC-RNA work in HFpEF and how it may overlap with his physiology-informed machine learning algorithm and phenotyping with the computational lab, Dr. Beard. So I thought the RNA work was tremendous. So any ideas how that collaboration might develop?
Dr. Beard's lab. Actually, I can leave my contact information for the first discussion, and some of my work focusing on the HFpEF with HDAC and RNA. I would be more than happy to do so. Thank you.
That's great. It would be a fantastic collaboration. Yeah, and I collaborate with Dr. Beard in another sphere and Dr. Hummel in another sphere. So I look forward to seeing that. Let me just see, are there more questions? Or Dr. Tang, if you see any questions.
Yeah, actually, I do have a question regarding the cardio oncology cohort. Actually, this cohort was built in 2000, almost 22 years ago. And how the idea came up, the source, and what's the fundamental ideas for the cohort, and what kind of the specific tumor you're looking into, or just the tumor and the chemotherapy will be included in this cohort?
I'll take this. So this cohort was actually built when I came to University of Michigan 4 years ago. We collected patient data from the initiation of our electronic medical record, and now it's prospective, and it's really focused on patients undergoing bone marrow transplantation, which, you know, it's a treatment for really various types of malignancies, both solid and also for some non-malignant condition. So the question here is really focused on cardiovascular complications of bone marrow transplant rather than a specific tumor. And it rose from the essentially clinical challenge of the pre-bone marrow transplant cardiovascular evaluation, which I do routinely in all our patients here at the University of Michigan, which is not evidence-based, it's really expert opinion-based, and we don't have guidelines to give providers, and all of the data out there is based on very old cohort from the beginnings of bone marrow transplant. So the question here is, you know, how do we perform a cardiovascular evaluation? Who can go through bone marrow transplant safely? And do we actually need to exclude certain cardiovascular patients from bone marrow transplant as is done traditionally? I hope that answers your question, Dr. Tang.
Yeah, thank you. That's beautiful. Thank you.
I have a question I think it's for Dr. Shen specifically. It's terrific you're building hamster models, and I know they've been very useful in studies of atherosclerosis. I know Dr. Chen's lab and Camtrast here at Michigan is building pig models, and I just would like your perspective on the various animal models. Between, we have the mouse models, you're developing elegant transgenic hamster models, pig models. How do you compare and contrast the different mammals for studying atherosclerosis?
So I think so when we compare, we just compare. So we can say the hamster is the good model for the lipid metabolism. So, and because the hamster has the the CETP gene. So I know the Professor Eugene Chen, they already studied this. And in the meantime, the hamster has the intestinal, the ApoB, intestinal ApoB editing. So I think the lipid profile of the hamster is very similar to the human. So I think the difficulty for this to compare the hamster and the pig, just because the size is totally different, right? So we know now the heart from the pig can be transplant to the human. So but for the hamster, the size is too small, and they cannot completely replicate the human disease. So I think so hamster has the the advantage and the disadvantage. So yeah, so it's now it's very hard to say which ones which model is perfect. So yeah, so I only can say the hamster just have the similar the metabolic features. So just in the field of the lipid metabolism. So for the pathology, because the vessel is totally different. So yeah, so it's hard to to say the hamster is better than the pig. So but I can say because now the mouse model is very so mature. They can be so easy to be delete the gene of interest or express the gene of interest into the mouse. So the technique it's premature. So it's mature than the hamster. So yeah, so I think so in the future, we have to develop mature techniques for the hamster. So including the antibody. So yeah, so to better study the cardiovascular disease in the hamster. So now it's I cannot say the hamster is the best one. So
no, it's great. It's like all animal models; they all have unique advantages. So you just shared the unique hamster advantages, and what an embarrassment of riches across the JI and our collaborations to have a full spectrum of large animal models. And we do have a gene bank. We're starting with some extremophile lipid phenotypes, work by Dr. Kristen Miller and others. So I look forward to hearing more. Dr. Tang, do you see any more questions? I'm not sure I see any.
No, I don't see any questions.
Okay, maybe it's time to just say thank you to the organizers and for the participants, and there will be sharing of all the contact information, right? The hope is by doing this, by the time we meet next time in person, we'll have some collaborations already well underway. Dr. Tang, do you have any final comments?
No, thank you very much. I think we have Dr. Collis for the closing remarks. Hello?
I know we're at time, and I'd just like to say congratulations. The spirit of collaboration, of discovery, of creativity is always so inspiring. So so thank you for really showing what the JI can do. I wish our colleagues in Ann Arbor a good day and a good evening, Beijing. Looking forward to being present with you in the future. Take care now.
Bye, everyone.
Thank you very much.